Malcom Pike, thank you very much for giving us a terrific lecture today. You changed the title, so you better tell me again what it was all about. But it was about mammographic density and how actually you persuaded us that that was superseded now by new technology. But in the meantime, you just talked us through the fact you don't get breast cancer if you haven't got breast tissue.
That's correct.
And it's all to do with the hormones. So give us it in a few sentences.
Okay, so what I was talking about was the fact that mammographic densities are the highest risk factor we know, except for these extreme things like BRCA1 and 2. They explain more of breast cancer actually than BRCA1 and 2 do. Right. We've been trying for a long time to work out why they work, and also whether you can use them to see whether chemoprevention is working.
Right.
Because most chemoprevention studies, like the P1 study here and so on, cost $100 million or more, and we simply can't afford it. We have to work out some way of knowing whether it's working.
So this is a measurement on the mammogram, plain two-dimensional mammograms. How white is it?
How white is it?
And that's going to be a biomarker, you hope. Or maybe that's the first part of the story, and you'll tell us the second part in a second or two.
Right.
So what about this density thing? And you've done some really interesting stuff in that area.
The more density you have, the more breast you have.
Yeah.
In other words, the more epithelial tissue, the more glandular tissue, and that explains about half of what the relationship is between densities and breast cancer. The other half we don't actually understand yet. Yeah. Initially it was thought that if you had more dense tissue, that therefore the breast cells inside the dense tissue would proliferate more. They would be driven to proliferation. But that actually isn't true. In fact, the breast tissue, the small amount of breast tissue in the fat is proliferating more than that's in the
collagen.
In the collagen.
Right.
But so that's still something we need to work out. But what recent studies have shown is that in fact in premenopausal women, when you put people on tamoxifen or they're oophorectomized, something like this, their mammographic density changes quite a lot, and that's a real biomarker that in fact you're going to have prevention from breast cancer on that.
So you could use that in the granddaughter of tamoxifen or a PARP inhibitor or whatever is coming out of the labs in the next 4 or 5 years.
That's absolutely right, but only in premenopausal women, I believe, because in postmenopausal women, changing the woman's hormonal status actually does virtually nothing to the mammographic densities. But my colleagues at Memorial Sloan Kettering, Dr. Morris and Dr. King, they actually spotted something going on with MRIs, that when a woman with BRCA1 or at high risk of breast cancer, she has an MRI, she also has contrast agent given to find the tumors. Well, they noticed that in fact the woman who got breast cancer, their contralateral breast actually was more enhanced by the contrast.
Wow. And
we've just published a study showing that the effects are really very, very large. They're actually larger than mammographic densities. And this is changed in postmenopausal women. It's changed in premenopausal women and postmenopausal women. Now what that represents, we're still trying to find out, but we think what it represents is that when you give anti-hormones, you cut cell proliferation in the breast, and this is somehow a marker of cell proliferation. I believe that what's happening is that when a cell divides, it needs nutrients, it sends out signals, you lay down new blood vessels, and it's these new blood vessels that you're seeing.
In both breasts?
In both breasts.
In the women who've got cancer?
Yes.
Yep.
So I think that we need much more work on MRI, other ways of doing it, because for normal women you can't really give contrast very often. Contrast's a little bit toxic, and what you really want is some new methods. And we heard a talk earlier today about using diffusion, and we're doing that work here at NYU with Dr. Jacot here. And that we're going to just set up now to see whether diffusion is the same as enhancement. So we just set that study up now, the last 15 minutes ago. This was one of the benefits
of coming to
these meetings.
And also we heard that magnetic resonance imaging might be going back to basics, where it all began, which was spectroscopy. And it would be so cool to have a little peek on a spectroscope scan of both breasts that would give you the clue.
Well,
and
I did such a study in 1985.
You did? Okay.
When I was at Oxford, I did it at the Oxford MRI unit. And unfortunately, at that stage, it didn't work. But I still think that's the right way to go.
That would be fantastic.
Yes.
Malcom, thank you so much again for giving us 5 minutes and telling us the really hot news of this whole conference. Thanks,
Thank you very much.